Hi everyone, welcome to the Health Economics Alongside Trial Special Interest Group webinars, applying the net benefits frameworks in trial-based cost-effectiveness analysis of case studies in arthroplastic prophylaxis. So my name is Nhung Nghiêm. I'm health economist and a modeler at the Australian National University. I'm a co-chair of HIPSIC with Lisa. Bunny, could you please move? Yeah. So we acknowledge the traditional custodians of the lands on which we live, work, and meet today, and pay our respect to their either past, present, and emerging. We extend that respect to Aboriginals and Torres Strait Islander peoples here today with us. And I'm from the Nganawas and Ngambri peoples in Canberra. So somehow skipping things, please use the chat function to ask questions at any time during the presentation. We encourage you to post your questions as they arise, and we will answer as many as possible during the Q&A question. A recording of the webinar will become available to watch on the ACTR website and ACTR YouTube channel. We would appreciate you completing a brief post webinar survey that will be distributed. So our speaker today, Associate Professor An Duy Tran, lists the health economic notes within the methods and implementation supports for clinical and health research hub at the University of Melbourne. He is also head of the health economics and simulation modeling unit at the Melbourne School of Population and Global Health. He has extensive experience in the design and conduct of trial-based economic evaluation across a wide range of clinical areas, as well as in the development of simulation models to inform healthcare decision-making. He has led and contributed to publication in leading international journals, including Value in Health, the New England Journal of Medicine, JAMA, the Lancet Respiratory Medicine, and Annals of the Rheumatic Disease. So welcome, Associate Professor An Duy Tran.
Thank you very much, Nhung, and hi everyone. Let me share screen for my presentation. I hope you see my screen.
Yes, I can see.
Okay.
Thanks.
Okay. Thank you very much for attending my presentation today. In this presentation, I will briefly introduce trial-based cost-effectiveness analysis, discuss why the net benefit framework provides a useful approach for decision-making, and then I will illustrate its application through a case study that evaluates the antibiotic prophylaxis in arthroplasty. I hope my presentation will provide some useful insights into the advantages of the net benefit framework over the traditional ICER or incremental cost effectiveness ratio-based approaches for statistical inference and its practical application using arthroplasty prophylaxis case study. First of all, a little bit about the trial-based cost effectiveness analysis. If you are not familiar with this, definitions, the trial-based cost effectiveness analysis is an economic evaluation conducted alongside a clinical trial using trial collected data to compare the cost and health outcomes of alternatives or competing interventions. In which, for the cost, we can collect healthcare costs or intervention costs or patient costs and productivity costs, depending on the perspective, whether or not healthcare system perspective or restricted or full societal perspective. In terms of effectiveness, there can be a wide range of clinical outcomes. For example, there can be changes in blood glucose levels or cardiovascular events avoided, or can be preference-based outcome, for example, quality-adjusted life years. The key features of the trial-based cost-effectiveness analysis includes patient-level resource use and outcome data are usually collected prospectively within the trial only. And then this analysis will be based on all the data collected within the trial and provides a direct estimate of the incremental cost and effects between interventions. Normally, with a trial-based cost-effectiveness analysis is conducted through randomizations instead of using observational study. So with the randomized trial, we can reduce bias in comparison of treatment effects and as well as healthcare resource utilization. And this is a form that is commonly used to inform decisions about the cost effectiveness of new intervention. The key analytical question in the trial-based cost effectiveness analysis is that is the additional health benefits of an intervention worth the additional cost? I'd like to make some distinctions between the inference or the conclusions or the information that can inform the decision in health economics and how they are different from the decisions in clinical settings. In clinical decision making, from the RCT or randomized control trials perspective, the primary question is that does the intervention improve health outcomes compared with the alternative? And normally RCTs are typically designed to test the superiority or non-inferiority hypothesis of an intervention. And the focus in the RCTs on whether there is a statistically significant difference in the primary clinical outcome between groups. And for the statistical part, the statistical inference is usually based on the null hypothesis testing to test whether or not there's no difference in the treatment effects. And then p-value and confidence interval are usually used for the treatment effects. For example, in the clinical trials that we conducted some time ago, the question was, does a prophylactic intervention, for example, adding vancomycin to the prophylaxis, reduce the incidence of infections compared with standard care? So this is something that the clinical trials try to answer. However, in health economics decision-making setting, the answer is quite different. The primary question is, does the intervention provide sufficient value for the additional resources required? The analysis is based on the assessment on whether the additional health benefits justify the additional costs. And then decisions are commonly informed by the incremental cost effectiveness ratios, or in short, ICER, which is compared with the cost effectiveness thresholds. It can be considered to be a price of each unit. It can be called units to pay threshold. So the focus is quite different from the clinical trials. The focus in this case is the decision uncertainty. That is the probability that an intervention is whether it's cost effective or not, rather than whether the ICER is statistically different from or lower than the threshold. So this is not related to the hypothesis testing. For example, the question is the additional cost of prophylaxis worthwhile given the health benefits gain? And then and now in this slide, we'll explain why the classic statistical inference for ICER is problematic. If you are not familiar with how the ICER is calculated, actually ICER is calculated by dividing the difference in expected cost by the expected health difference in health outcomes. So delta C over delta E. And normally, if you think about the clinical trials, the statistical inference is based on the sampling distribution. But this is problematic if you look at the characteristics of the ICER. Now, ICER is based on the delta C and delta E, and there are different cases and different situations for the combination between delta E and delta C. So delta E represents the difference in the effectiveness and can be larger than 0, smaller than 0, or equal to 0. In the case of delta E is larger than 0, the large magnitude is desirable because we try to have maximize the health gain. So we want to maximize delta E. And in the case, if the delta E is smaller than 0, we want to have this minimize the difference as much as possible. So in this case, the new intervention is less effective compared to the usual care. We want to the delta E to be close to 0 as possible, so small absolute values is desirable. In case of delta C, similarly, we have delta C is larger than 0, delta C is smaller than 0, or delta C is 0. And in the case of delta C is larger than 0, we want to minimize the cost, so it means that small value is desirable. In the case of delta C is smaller than 0, we want to deal the difference between the intervention because interventions, we want to increase the saving. So we want to have as small cost as possible. So large absolute value is desirable. So when we combine the delta C and delta E, the ICER, in this case, for example, if the delta C is larger than 0, delta E is larger than 0, then ICER is larger than 0. So we want to have as small ICER as possible, because a smaller ICER indicates that the smaller cost and larger health benefits. And then when it comes to, it's the same case if delta C is larger than 0, but the delta is smaller than 0, and then ICER is smaller than 0. And this also happened in the case of delta is smaller than 0, but delta is larger than 0. So we have two cases of ICER smaller than 0 here. But these have different interpretation. For example, when delta C is smaller than 0, we have problematic with magnitude because we don't know if the ICER should be large or small to favor the intervention. For example, when the delta is very small, this will drive ICER towards 0. And when the very small ICER, because in this case, we want to have a small delta C, but very small delta C will drive ICER towards 0. And in this case, we want to have a small absolute value of delta E, but the very small absolute value of delta will drive ICER towards negative infinity. So it means that the range of ICER can go from negative infinity to 0, and we have a problem with interpretation of magnitude. We cannot say that we want ICER to be large or to be small because it's that they have a different interpretation. Similarly, in the case of ICER smaller than 0, but in this case, delta C is smaller than 0 and delta E larger than 0, then you see here the large absolute value of delta C is desirable, but the very large absolute value of delta C that drives ICER towards negative infinity, and very large delta E will drive ICER towards 0. And again, similar to this case, to another case, then you have a problem with the magnitude of the ICER. And when delta C is 0 and delta E is larger than 0, then ICER is 0, then the interpretations on delta E interpretation of ICER depends on delta E. And then when you have a delta E is 0 and delta C is 0, then you have undefined ICER. So the magnitude of ICER cannot always be consistent to answer the question whether or not we want to have an maximize ICERs or minimize ICER. So that's a problematic with the statistical inference of ICER, and then we cannot, based on the sampling distribution of ICER, to draw conclusion or informed decisions on ICER. And then the net benefit framework was introduced. Benefits can be expressed in two terms, either health benefits or monetary benefit. In terms of the net health benefit, the net health benefit is calculated for individual as the expected value of the health outcomes minus the expected value of a cost divided by lambda, in which lambda is a cost effectiveness threshold. And as I mentioned previously, lambda can be understood as the price per unit gain in the effectiveness. So it means that if the person, when the receiver intervention has the expected value of health effectiveness is E, and then they have investment in the intervention as the C, and C divided by lambda represents some kind equivalent to health loss. So when they gain the health outcomes as E, the E minus C divided by lambda represent the health gains for that person. And then when we compare two interventions, we have incremental net health benefit, and incremental net health benefit is calculated by actually for intervention 2 is calculated as E2 minus C2 divided by delta, and then for intervention 1 in this case is divided equivalent to E1 minus C1 divided by lambda, and with at least a very simple arrangement, you have incremental health benefits equivalent to delta E minus delta C divided by lambda. And in analogy, we can use net monetary benefit to inform decision. And in this case, net monetary benefit is equivalent to net health benefit multiplied by lambda. Think about each unit of effectiveness equivalent to a price called lambda. So you multiply net health benefit with lambda, we come up with net monetary benefit. And if you look at the definition of incremental net health benefits of formula delta E minus delta C divided by lambda, when you multiply this with lambda, we come up with the delta E multiplied by lambda minus C. And then similarly, you have incremental net monetary benefit, which is calculated as delta E multiplied by lambda minus delta C. So why this is superior compared to ICER in interpretations of the findings from the cost effectiveness analysis? Let's take a look at the different situations as in previously tabled. So we have different situations here. We have delta E larger than 0, delta E smaller than 0, and delta E is equal to 0. Then you have delta C larger than 0, again, delta C smaller than 0, and delta C is equal to 0. In the case of delta E larger than 0 or smaller than 0, or delta C larger than 0 or smaller than 0, you come up with the same interpretation for the net monetary benefits or net health benefit. So in the case of if ICER is smaller than the threshold, both incremental net health benefits larger than 0 and incremental net monetary benefits also larger than 0. So they are consistent. And then the large magnitude is desirable because we want to maximize net benefits in this case. And then when it comes to delta C is equal to 0, and then we also have both net health benefits and net monetary benefits larger than 0, and large magnitude is desirable. Then when the delta is 0, we have the in different situations. If delta C is larger than 0, you have both incremental net health benefits and net monetary benefits loss smaller than 0. And then when delta C is smaller than 0, you have both incremental net health benefits and incremental net monetary benefits larger than 0. So by using the net benefits, we can interpret the informed decision consistently, regardless of whether or not the combination of delta C or delta E are different in different situations. Then comes questions whether or not we should apply the classic statistical inference on net health benefits or net monetary benefits, whether we should calculate the 95% confidence intervals or do some inference about that to compare net health benefits to zero with a hypothesis whether or not they are statistically different from zero. And there has been several debates surrounding that. And I think now most of the people accept the arguments that the inference of net health benefits or net monetary benefits are irrelevant. And for your information, you can look at this paper and go through that to understand why classic statistical inference on net monetary benefits is irrelevant. So that's some basis about the net monetary framework. Then I come to the case study. Recently, we published a study on the economic evaluations of the addition of vancomycin to cefazolin prophylaxis in patients undergoing arthroplasty. You can see here the group of authors, and this is based on the data collected from the ICERs trial. Some background about the study. A little bit about arthroplasty and surgical site infection. Arthroplasty is just like the procedure for joint replacement, like knee replacement, hip replacements, and usually this is considered to be very effective treatments for the end-stage arthritis. Because it can improve pain functions and can improve the health-related quality of life in the patients with the condition. And the demands for arthroplasty is rising rapidly due to the increase in osteoarthritis prevalence. If you look at the projections of the total knee replacement, for example, from 2003 to 2030 in Australia, and with assumptions that the procedure rates continue to increase as they have in the past. And from 2003, you see that there were about 20,000 procedures in total knee replacement in Australia. But in 2030, this is projected to increase to 160,000 procedures. So this is a substantial increase in the procedures. And despite the benefits and risks characteristics of this procedure, the surgical site infections remain a major complications. When people with this procedure have the surgical site infections, they can be affected a lot in terms of mobilities and in terms of quality of life and have poorer outcomes. And then surgical site infections are associated with the expensive revision surgeries and can prolong healthcare use. So preventions of surgical infections is clinical and economic priority in arthroplasty. And so in previous study published in the New England Journal of Medicine, the group and a co-author of this publication, we found that the addition of vancomycin to prophylaxis arthroplasty didn't reduce the proportion of patients with surgical site infection at 90 days. And that's just a little bit about the prophylaxis in arthroplasty. In usual care, cefazolin is the standard antibiotics to prevent the surgical site infection. Several authors have suggested that adding vancomycin can improve the coverage against the antibiotic-resistant bacteria. For example, cefazolin is not very effective in people with methicillin-resistant, such as Staphylococcus aureus, And there's some evident gaps here. The efficacy or the effectiveness of adding vancomycin to cefazolin, the findings from that are mixed. Some clinical trials found that adding vancomycin to cefazolin reduced the rate of infections. But in our study recently, with a very large sample size, we found no reduction in the proportion of patients with SSIs at 90 days between vancomycin plus cefazolin and cefazolin alone. So the question is that if we found no differences in the health outcomes in terms of the infection between the two groups, why would we do the economic evaluation? Actually, we didn't examine the severity in the analysis, like analyze the severity of the surgical infections, and also the timing of the infection. And quality of life, normally when the people experience the infection, the quality of life is reduced, but then the quality depends on the timing of the quality of life. So the timing of the infection actually affects the qualities. Even if in two groups, even if the proportion of people experience the infection are the same, but the timing and severity, if they are different, they can affect the differences, affect the qualities at the end. And also in the previous study in the publication, we didn't calculate the healthcare costs and implications of the adding vancomycin to cefazolin, how they affect the healthcare costs. And we didn't calculate the qualities and cost effectiveness of this intervention. So that's why we conducted the academic evaluations of adding vancomycin to cefazolin. The study design, a little bit about this. This is a double-blind, multi-center RCT conducted at 11 Australian hospitals, and participants were adults undergoing arthroplasty without known methicillin-resistant SA. So SA stands for Staphylococcus aureus colonization, this kind of bacteria. The randomization was conducted at 1:1. The intervention was vancomycin plus cefazolin, and the comparator was placebo plus cefazolin. Then 4,113 patients were included in the modified intention to treat analysis. We call it modified intention to treat analysis because a number of people were excluded after registrations or after randomization to intervention. For example, in the vancomycin group, 74 people were excluded and 20 people withdrew consents, or some people didn't undergo surgery. So that's why we call it modified intention to treat analysis. In the vancomycin group, there were 2,044 patients. In placebo groups, there were 2,069 patients. So the number were quite similar. The recruitment started on January 2019 and onwards up, and then the follow-up time was 180 days after the surgery. The data collections at the baseline, demographics, height, weight, diabetes status, and MRSA screening were collected. And then clinical and patient-reported outcomes were collected at baselines, 30 days, 90 days, and 180 days. We collected EQ5D 3L. You might wonder why we didn't use EQ5D 5L, because by the time the trial was designed quite a long time ago, the value sets, Australian value sets for EQ5D 5L was not available. So we decided that we use EQ5D 3L, and the value set for this instrument was available. Then surgical site infections and other adverse events were collected. In terms of the healthcare resource use, primary care and patient service were collected through the Now, collectibles were obtained through the Medicare benefits schedule claims, and medication use were estimated by the Pharmaceutical Benefits Scheme, PBS dispensing records. Then hospital care were estimated through the administrative data from participating hospital. Then there was data linkage that MBS PBS records were linked by Services Australia, and hospital administrative data linked by participating hospital using unique patient identifiers. In the cost effectiveness analysis, we conducted this from the Australian healthcare sector perspective. The cost included prophylactic antibiotics based on PBS prices, and then non-hospital healthcare use were estimated based on MBS PBS records. Because we use the healthcare sector perspective, so we include also patient out-of-pocket cost in the MBS PBS, so patient contribution to the medication and healthcare services. We use hospital readmission costs from hospital administrative data for calculating hospital costs. Then the costs were reported in 2022 Australian dollars. 2022 was the end years of the study. The health outcomes were assessed through the EQ5D 3-hour responses and were converted to health utility using Australian value set. Then quality adjusted life years, QALYs, estimated over the 180 days follow-up. For the analysis, because of the distribution of the cost and outcomes, costs, I think mainly costs, were very highly skewed. So we used the bootstrap methods with 10,000 bootstrap replication to estimate the mean and 95% confidence intervals. And uncertainty analysis were assessed using the cost effectiveness plans and the cost effectiveness acceptability curves. In the uncertainty analysis, we used the bias corrected accelerated bootstrap in which 10,000 replications of incremental costs and QALYs were plotted on the incremental cost effectiveness plan. Then in the study, we applied the net monetary benefit framework to determine whether intervention was cost-effective at different willingness to pay or willingness to accept threshold, in which we assume that the willingness to pay were equal to willingness to accept. Of course, if you look at the literature, there are quite some debates about whether or not willingness to pay should be approximated to willingness to accept. In this case, to make it simple, we make this assumption. And then the cost effectiveness acceptability curve was constructed to estimate the probability that the intervention is cost effective. So how were these probabilities estimated? We look at the distributions of the replications of incremental cost and QALYs on the cost effectiveness plan. And for each plan, we calculate the proportion of the bootstrap replication with a positive incremental net monetary benefits at each willingness to pay or willingness to accept threshold. Now, some regions, the baseline characteristics of study cohort. And here I just extracted some characteristics of patients. You can see that the characteristics of the patient between the two treatment groups are very similar. For example, the mean age was 6.6 or 67 in vancomycin and placebo groups. And p-value was 0.14, indicating that there were no significant differences between mean age in mean age between the two groups. Male and female percentage are very similar. Female as a proportion is 52%. Then the affected joints, the knee, hip, shoulders, replacements, and most of the patients have a knee and hip replacement proportion equal to 54% and 45% respectively. And again, there were no statistically significant differences in the proportions of the affected joints. The operation time, primary and revisions, the proportions are very similar. And diabetes, around 12% of people had diabetes, but there was no significant difference between the two groups in the proportions of diabetes, people with diabetes. Current smoker, no significant difference again, and health utility at baseline were 0.53 in the two groups, and they were not significantly different. The health utility over progressions over 180 days. In this, you can see the strip plots of the ECO5D 3Ls at baseline, 30, 90, and 180 days. The strip represent the vertical distributions of the utilities, and the diamond represent the mean values. Then the diamonds has a very small, very short area, but sometimes you cannot see because the 95% confidence intervals are very small. So you can see that as baseline, the health utilities are almost identical between the two treatment groups. And then utilities increase over time. So we can see the improvements in quality of life over time after the surgery. And at the end of the study period, the utilities increase up to 0.88, almost the same between the two groups. You look at healthcare costs and health outcome over 180 days. We can see that the treatment costs are quite a difference between the two treatment groups. In vancomycin, the mean cost per patient for the vancomycin plus cefazolin is around $103, and in placebo group is only 4.7. The difference is almost $100. Non-hospital costs, the mean in the vancomycin groups and placebo group are quite similar, but actually in vancomycin group, there's slightly larger non-hospital costs compared to the placebo group, with the difference is around $40. In terms of hospital costs, we look at the hospital costs across all participants and across among those who were readmitted to a hospital. So in terms of the cost across all participants, the average is quite small because most of the people were not readmitted to hospital. So the average was around $170 or $180 in the vancomycin group and around $150 in the placebo group. But among those who readmitted, so this represents actual hospital costs for readmission. For the vancomycin group, it was around $21,000 per readmission, and in placebo group, around $25,000 per readmission. When we add all the treatments, all the costs together, including treatment costs, non-hospital and hospital costs together, then the total healthcare costs for all participants were around $5,200 for vancomycin groups and around $5,020 for placebo group. The difference in $166,000. So it means that actually adding vancomycin to cefazolin increase the total healthcare cost. So my wonder why the vancomycin not increased, but was associated with the increased infection rates and was associated also with increased total healthcare costs. The actual mechanism is unknown, but our hypothesis was that when we add the vancomycin to cefazolin, they might alter the balance of bacteria, which is known as antimicrobial selection pressures. So antibiotics kill susceptible bacteria while allowing less susceptible organisms to survive and proliferate. So actually, combination of prophylaxis could have favored the emergence of more severe virulent MSSR strains, so the resistant strains, and they have a greater ability to infect. So, or they may alter the microbial environment in a way that increase infection caused by gram-negative bacteria. That's the reason why they may be associated with increased proportion of people experiencing infections or the healthcare costs. The qualities in the two groups were calculated as quite similar, 0.39 and 392. The difference very small. 392 in the vancomycin group and 0.394 in the placebo group. And in terms of the infection counts, 0.47% of people in vancomycin groups experienced infections, and 0.38% in the placebo group experienced infection. Now, when we combine the incremental cost and incremental quality and put them on the incremental cost effectiveness plan, you can see that the replications, so they across, so each dot represent the expected incremental cost and incremental quality. They scatter in all four quadrants of the plan. English in the northwest quadrant, 63% of the dots are present in this quadrant. And this quadrant represents that the interventions is less effective and more costly. On the northeast quadrant, we have a 17% of the replications, and this represents that the intervention is more costly and more effective. So, to inform decision, we need the threshold or willingness to pay to determine whether or not the intervention is cost effective. On the southeast quadrant, you see that only 5% of the replications are lying in this quadrant. This quadrant represents the case where the interventions is more effective, less costly, but this is represented by a very, very small percent. Then we go to the southwest quadrant. We have 14.7% of the replications, and this quadrant represents that indicates that the intervention is less effective and less costly. So to inform the decision, we need the willingness to accept to see that the cost savings is justified by the healthcare loss, health outcomes loss is justified by the saving. Then applying the net monetary benefits, we increase the willingness to pay or willingness to accept threshold from 0 to a value at which there were almost no change in the probability of the intervention being cost-effective. And here we plot the reverse of the normal cost-effectiveness acceptability curve, representing the probability of the intervention is not cost-effective instead of cost-effective. We see that at baseline, the probability of the adding vancomycin is associated with around 0.8 probability of not cost-effective. And then the probability of not cost-effective increase a little bit and then go down and stabilize for the threshold beyond 3 million. And at the end, you see that the probability of not cost-effective is around 0.8. So the conclusions on the findings, this is the first economic evaluation of the addition of vancomycin to cefazolin prophylaxis. And we proved that the net monetary benefit framework provides an efficient approach for uncertainty analysis, in which we calculated that, estimated that 63% probability of being more costly and less effective of the intervention. And we estimated that larger than 79% probability of not being cost-effective at any positive willingness to pay thresholds. So the implication of this analysis is that at current arthroplasty volume, approximately around 150,000 procedures performed annually, avoiding unnecessary vancomycin could save larger than $12 million nationally. So that implication in terms of economic implications. And our findings in both main analysis for clinical trials and these economic evaluations support the antimicrobial stewardships by reducing unnecessary antibiotic exposure and potential antimicrobial resistance. There are some strengths and limitations in our analysis. The strengths that this is based on very large multi-center randomized trials with more than 4,000 patients. And with your national linkage of MB and PBS are also linkage to hospital data to calculate the healthcare cost. And then we use robust uncertainty analysis using bootstrap methods for this analysis. Some limitations. These are trial-based economic evaluations and captures only short-term outcomes. Although most of the infection occur during the 90 days, as found out from the main analysis. So we can be confident that the 180 days can provide the sufficient long period to capture healthcare costs, but actually it does not capture the long-term consequences of antimicrobial resistance. Because routine prophylactic vancomycin might contribute to antimicrobial resistance. So the increase in the antibiotic exposure can promote emergence and spread of resistant organisms. And antimicrobial resistance imposes future costs on patient and healthcare system, which cannot be captured within a trial-based economic evaluation. So,
sorry to interrupt, Anh An. We have two questions from the participants. I mean, I could wait for you to run the last slide, but we have about 5 minutes. If you're happy to answer the question now, or you want to just wrap up in a couple of minutes and answer the question.
Okay, I have only a number of slides left, so I will go through this and we'll answer at the end of presentation. This okay? Yeah. All right. Thank you. So some thoughts about how we can capture the long-term impact of antimicrobial resistance and its economic burden. So what do we need to know? That the trial cannot give us the data to answer this question. The first question is which resistant pathogens are directly or indirectly affected by combination prophylaxis. In this case, vancomycin plus cefazolin. As discussed earlier, our hypothesis that the use of both vancomycin and cefazolin may alter the balance of bacteria. Therefore, we need to know which resistant pathogens are directly or indirectly affected by this combination. While we know major resistant pathogens affected by routine use of vancomycin, such as methicillin-resistant Staphylococcus aureus, the primary target of vancomycin prophylaxis is mainly to prevent the MRSA surgical site infection. But I think there's a concern about major antiviral stewardship because there are a chance that other organisms may be indirectly affected by adding vancomycin to cefazolin. And then the next question is how the combination of prophylaxis changes the incidence of resistant infection and how resistant organisms spread within the population. Then the long-term health and economic burden attributable to the antimicrobial resistance need to be known. Then we need to know the value of antimicrobial stewardship, especially in reducing antimicrobial resistance and improving health outcomes. In here, some thoughts about towards modeling the long-term value of antimicrobial stewardship. I'm not the infectious disease modeler, so I did conduct some literature reviews and see that maybe that's a way to model the long-term value of antimicrobial stewardship through these objectives. We'll go through the objective for this exercise. That first thing we need to model the effects of prophylactic acrobiotics on pathogen ecologies and AMR. The possible modeling approach could be the population genetics within house or ecological models to estimate how antibiotic exposure changes the pathogen composition and resistance. The next objective is capture transmission of resistant organisms at a population level. Some approaches could be dynamic transmission models or agent-based model to simulate the spread of resistant organisms. And then when we know the antimicrobial resistance, which we need to link that burden to future infections and healthcare costs and qualities. Looking at literature, I saw that the people have conducted using decision trees, Markov model, microsimulation, or discrete event simulation to estimate long-term clinical and economic outcomes. Then we can compare the alternative in prophylactic and stewardship strategies by using decision analytic model to compare different antibiotic policies. Then finally, we should estimate the long-term cost effectiveness of antibiotic policies, and some possible modeling approaches can be dynamic transmission economic models by linking transmission and health economics or hybrid models. So the future work may require a hybrid modeling framework integrating transmission dynamics with decision analytic modeling for economic evaluation in this case. And I mean, to me, this is a very exciting opportunity and also challenging opportunity to solve this problem. So this is the end of my presentation. I'd like to acknowledge and thank Australian National Health and Medical Research Council for supporting this work, and then the methods and implementation support for clinical and health research mission at the University of Melbourne for supporting me in making this webinar. Thank you very much. That's all from me. And if you have any questions, please send me email as shown on this slide. Thank you very much.
Thank you, and very interesting and very informative presentations. I think we have two questions from the participant in the chat box, and I think Stephen just raised a question. Would you like to respond to the questions in the meeting chat?
Yeah, let me go through.
Bedru, would you like to raise your question? That you walk through your question with An?
Yeah. So the first question is from Bedru. Great presentation. Thank you for sharing this. I wanted to ask whether conference info are reported and used for interpretation in this analysis, as we usually do in RCA analysis. Yes, I'm not sure if you mentioned conference interval for the baseline characteristics or cost. Well, actually, if your question is what about the conference interval for cost and health outcome, yes, we did report that. But actually, as mentioned previously, was no conference interval for net monetary benefits or ICERs, or because it was not considered to be not the preferable or not desirable approach. And then the next question also the same participant. In cost effectiveness analysis, if the bootstraps estimates on the cost effectiveness plans are distributed across all four quadrants, how should we interpret cost effectiveness? And can we base the conclusions on percentage of estimates in the southeast quadrant? It is very, very interesting and I think very relevant question. And as I explained, using net monetary benefits or net health benefits, and with the willingness to accept, willingness to pay. So if you look at the quadrant, you see that there are only two quadrants that, so the north, east, and then the southwest unfolds in the use of willingness to pay or willingness to accept. The quadrants on the north west represent that intervention was less costly and less effective and more costly. So it means that intervention dominated. And the quadrant, the southeast quadrant represent the case where the interventions is more effective and less costly. So the intervention dominates. So in this case, we can see that the intervention dominates the use care. But to combine all the quadrant, we use the net monetary benefits consistently for each case to calculate the proportions of the intervention being cost effective to draw the conclusion on this. I hope my answer address your questions, or just feel free to.
Thank you, Anh. Yeah. Thank you again. Sorry, we have another question from Stephen. And Bernie, could you please run through the slides from the hit slide? Stephen, could you please ask the question now? And could you please stop sharing your slides?
Yeah.
So that Bernie can. Yeah.
I have two questions. The first is, was vancomycin always given before the first skin incision with the arthroscopy? And the second question is, how did you deal with deaths on the study?
Okay, so can you repeat the first question again? Do you mean the antibiotics were given before
the vancomycin? Ordinarily, I would have thought should have been given 30 minutes or 15 minutes or so before the first skin incision.
Yeah, the first arthroplasty procedure, right?
Correct.
Yeah. So both in the RCT, as far as I recall, both vancomycin and cefazolin were given, I think, around that time before the procedure. And in another arm is only cefazolin was given and the plus placebo. And then in terms of the death, how we didn't observe deaths, so there were no censoring
Did you
costs.
collect data on deaths to 180 days?
No, we didn't observe during that period. Yeah, I think in the RCT deaths were collected, but over 180 days, I didn't observe any deaths in the data analysis.
Good, thank you.
Anh Anh, Bunny, could you please share the slide? Thanks, Bunny. Okay, so thank you very much for everyone for attending the webinar, and thank again and for very interesting and informative presentations. So we would appreciate if you could please complete a brief webinar survey to give your feedback for today's section, and also please let us know what topic you would like to learn more about in the future webinars. And I think that we're still looking for the next suggestion for the next webinar. Bunny, could you please move to the next slides? Yeah, so suggestions welcome. And thanks again, everyone. I would like to draw the webinar to close now.